Chapter 28, Concepts of Care for Patients with Dysrhythmias. The priority concept of this chapter is perfusion. So what is perfusion? Perfusion is the process by which blood is delivered to tissues in the body, providing essential nutrients and oxygen while removing waste products. In the context of medical science, perfusion refers to the circulation of blood through the vascular system to organs and tissues, ensuring their proper function. Without adequate perfusion, organs and tissues can suffer damage or even failure due to a lack of oxygen, leading to severe health consequences. Perfusion is part of the cardiovascular system's essential function, ensuring that the heart pumps oxygen-rich blood to tissues and organs. The circulatory system consists of two primary parts: the systemic circulation, in which this type of circulation, blood is pumped from the heart to all body tissues, delivering oxygen and nutrients. And the second is the pulmonary circulation. Blood is pumped to the lungs to exchange carbon dioxide for oxygen. In healthy individuals, the body continuously maintains adequate perfusion to sustain life. However, in certain medical conditions or during surgeries, perfusion may be disrupted, necessitating the use of artificial systems, such as ventilation, to ensure blood flow continues efficiently. Disruptors to circulation are clotting, fluid, and electrolyte imbalances. Key concept for this chapter is the cardiac conduction system. There are two key terms regarding conduction, and they are conductivity, the ability of a cell to send an electrical stimulus from cell membrane to cell membrane, and contractility, the ability of the atrial and ventricle muscles to push blood flow forward through the heart, the mechanical activity of the heart. The way this flows through, it goes from the sinus node to the atrial tract, to the atrium, to the intranodule tract, the AV node, the bundle of His, the bundle branches, and then the Purkinje fibers, which lead into the ventricles. The conduction system is assessed utilizing an ECG, or an electrocardiogram. Conduction begins with the SA node, or the sinoatrial node. It's located close to the surface of the right atrium, near its junction with the superior vena cava. The SA node is the heart's primary pacemaker. It generates electrical impulses at a rate of 60 to 100 beats per minute, and therefore has the greatest degree of automaticity, or pacing function. The SA node is richly supplied by the sympathetic and parasympathetic nervous systems, which increase and decrease the rate of discharge of the sinus node, respectively. This process results in changes in the heart rate. It will raise the heart rate or lower it in response to what the body needs. Impulses from the sinus node move directly through atrial muscle and lead to atrial depolarization, which is reflected in the P wave of an ECG. Atrial muscle contraction should follow. Within the atrial muscle are slow and fast conduction pathways leading to the AV node, or the atrioventricular node. The atrioventricular node junction consists of a transitional cell zone, the AV node itself, and the bundle of His. The AV node lies just beneath the right atrial endocardium, between the tricuspid valve and the ostium of the coronary sinus. Here, T cells, or transitional cells, cause impulses to slow down or be delayed in the AV node before proceeding to the ventricles. This delay is reflected in the PR segment of the ECG. This slow conduction provides a short delay, allowing the atria to contract and the ventricles to fill. The contraction is known as an atrial kick and contributes additional blood flow volume for greater cardiac output. The AV node is also controlled by both the sympathetic and parasympathetic nervous systems. The bundle of His connects with the distal portion of the AV node and continues through the intraventricular septum. The bundle of His extends as the right bundle branch down to the right side of the intraventricular septum to the apex of the right ventricle. On the left side, it extends as the left bundle branch, which further divides. At the end of both the right and the left bundle branch systems are the Purkinje fibers. These fibers are an interweaving network located at the endocardial surface of both ventricles from the apex to the base. The fibers then partially penetrate into the myocardium. Purkinje fibers make up the bundle of His, the bundle branches, and terminal Purkinje fibers. These cells are responsible for the rapid conduction of electrical impulses throughout the ventricles, leading to ventricular depolarization and the subsequent ventricular muscle contraction. A few nodal cells in the ventricles are occasionally demonstrated automatically, giving rise to ventricular beats or rhythms. The cardiac conduction system consists of specialized myocardial cells. The electrophysiologic properties of these cells regulate heart rate and rhythm and possess unique properties: automaticity, excitability, conductivity, and contractility. Let's go into those terms a little bit. When we talk about automaticity, that's the pacing function. It's the ability of cardiac cells to generate an electrical impulse spontaneously and repetitively. Normally only the SA or sinoatrial node can generate an electric impulse. However, under certain conditions such as myocardial ischemia, which is a decreased blood flow to the heart, electrical imbalances, hypoxia, drug toxicity, and infarction or cell death, any cardiac cell may produce electrical impulses independently and create dysrhythmias. Disturbances in automaticity may involve either an increase or a decrease in pacing function. Excitability is the ability of the non-pacemaker heart cells to respond to an electrical impulse that begins in the pacemaker cells. Depolarization occurs when the normally negatively charged cells within the heart muscle develop a positive charge. Conductivity is the ability to send an electrical stimulus from cell membrane to cell membrane. As a result, excitable cells depolarize in rapid succession from cell to cell until all cells have depolarized. The wave of depolarization causes the deflection of the ECG waveforms that are recognized as the P wave and the QRS complex. Disturbances in conduction result when conduction is too rapid or too slow, when the pathway is totally blocked, or when the electrical impulse travels an abnormal pathway. Contractility is the ability of atrial and ventricular muscle cells to shorten their fiber length in response to electrical stimulation, causing sufficient pressure to push blood forward through the heart. In other words, contractility is the mechanical activity of the heart. This is the setup for a standard 12-lead EKG. What that means is the standard 12-lead EKG consists of 12 leads or views of the heart's electrical activity. 6 of the leads are called limb leads because the electrodes are placed on the 4 extremities in the frontal plane. The remaining 6 leads are called chest or precordial leads because the electrodes are placed on the chest in a horizontal plane. Standard bipolar limb leads consist of all 3 leads 1, 2, and 3, and each measure the electrical activity between 2 points and the 4th lead or the right leg that acts as a ground lead. Of the 3 measuring leads, the right arm is always negative, the left leg is always positive, and the left arm can be either positive or negative. Other lead systems include the 18-lead ECG, which adds 6 leads placed on the horizontal plane on the right side of the chest to view the right side of the heart. This is sometimes referred to as a right-sided ECG. The extra leads are sometimes placed on the back. Unipolar limb leads consist of a positive electrode only. The unipolar limb leads are the AVR, AVL, and AVF. This has an A in front of the lead because it means that it's augmented. V is a designation for a unipolar lead. The third letter denotes the positive electrode placement. R for right arm, L for left arm, F for foot or left leg. The positive electrode is at one end of the lead axis. The other end is the center of the electrical field, at about the center of the heart. There are 6 unipolar or V chest leads, determined by the placement of the chest electrodes. The 4 limb electrodes are placed on the extremities as designated on each electrode: right arm, right leg, and left leg. The 5th chest electrode on the monitor system is the positive or exploring electrode and is placed in one of the 6 designated positions to obtain the desired chest lead. With a 12-lead ECG, 4 leads are placed on the limbs and 6 are placed on the chest, eliminating the need to move any electrodes about the chest. Now that we know where to place the ECG leads, let's look into the electrocardiographic waveforms. So this is what the ECG paper looks like. When we're looking at this, we see that there's a whole bunch of boxes. So let me explain to you what those are. So with an ECG strip, it's printed on graph paper. Each small box measures 1 millimeter in height and width. The ECG recorder and monitors are standard at a speed of 22 millimeters per second. Time is measured on the horizontal axis. At this speed, each small box represents 0.04 seconds. 5 small boxes make up one large box, defined by the dark bold lines and representing a 0.20 second, so 0.20 seconds. 5 large blocks represent 1 second, and 30 large blocks represent 6 seconds. Vertical lines in the top margin of the graph paper are usually 15 large blocks apart, representing what's called a 3-second segment or 3-second strip. One of the quickest ways, but also the most inaccurate way to calculate a patient's heart rate is by utilizing a 6-second strip. In the image above, each segment between the dark lines above the monitor strip represents 3 seconds when the monitor is set at a speed of 25 millimeters per second. To estimate the ventricular rate, we count the QRS complexes in a 6-second strip and then multiply that number by 10 to estimate the rate for 1 minute. In this example, there are 9 QRS complexes in 6 seconds. The heart rate can be estimated to be about 90 beats per minute. In this next section, we're going to talk about the ECG complexes, segments, and intervals. Complexes consist of your P wave, your QRS complex, your T wave, and possibly a U wave. The segments are the PR segment, the ST segment, and the TP segment. And then our intervals are the PR interval, the QRS duration, and the QT interval. What we're looking at here is a normal ECG waveform. Let's talk about what we're seeing. The P wave is a deflection representing atrial depolarization. The shape of the P wave may be positive, negative, or biphasic, both positive and negative deflection, depending on the lead selected. When the electrical impulse is consistently generated from the SA node, the P waves have a consistent shape in a given lead. If an impulse is then generated from a different or an ectopic focus, such as an atrial tissue, the shape of the P wave changes in that lead, indicating that an ectopic focus has fired. The PR segment is an isoelectric line from the end of the P wave to the beginning of the QRS complex, when the electric impulse is traveling through the AV node where it's delayed. It then travels through the ventricular conduction system to the Purkinje fibers. The PR interval is measured from the beginning of the P wave to the end of the PR segment. It represents the time required for atrial depolarization, the impulse delay in the AV node, and the time travel to the Purkinje fibers. It normally measures from 0.12 to 0.20 seconds, or 5 small boxes. The QRS complex represents ventricular depolarization. The shape of the QRS complex depends on the lead selected. The Q wave is the first negative deflection and it is not present in all leads. When present, it is small and represents initial ventricular septal depolarization. When the Q wave is abnormally present in a lead, it represents myocardial necrosis or cell death. The R wave is the first positive deflection. It may be small, large, or absent depending on the lead. The S wave is a negative deflection following the R wave and is not present in all leads. The QRS duration is the time required for depolarization of both ventricles. It is measured from the beginning of the QRS complex to the J point, or the junction where the QRS complex ends and the ST segment begins. It normally measures less than 0.11 seconds, or 2.5 small boxes. The ST segment is normally an isoelectric line and represents early ventricular repolarization. It occurs from the J point to the beginning of the T wave. Its lengths vary with changes in the heart rate and administration of medications, also electrolyte disturbances. The T wave, which follows the ST segment and represents ventricular repolarization. It is usually positive, rounded, and slightly asymmetric. T waves may become tall and peaked, inverted or negative, or flat as a result of myocardial ischemia, potassium or calcium imbalances, medications, or autonomic nervous system effects. The U wave, when present, follows the T wave and may result from slowed repolarization of the ventricular Purkinje fibers. It is of the same polarity of the T wave, although generally it is smaller. It is not normally seen in all leads and is more common in lead V3. An abnormal U wave may suggest an electrolyte abnormality, particular hypokalemia or low potassium, or other disturbances. Correct identification is important so that it is not mistaken for a P wave. If in doubt, notify the primary health care provider and request that a potassium level be obtained. The QT interval represents the total time required for ventricular depolarization and repolarization. The QT interval is measured from the beginning of the Q wave to the end of the T wave. This interval varies with the patient's age and gender and changes with the heart rate, lengthening with slow heart rates and shortening with fast heart rates. It may be prolonged by certain medications, electrolyte disturbances, or subarachnoid hemorrhage. A prolonged QT wave interval may lead to unique types of ventricular tachycardia, or VTAC. This type is particularly called torsades de pointes, and it is related to a low magnesium level. Artifact is interference seen on the monitor or the rhythm strip, which may look like a wandering or fuzzy baseline. It can be caused by patient movement, loose or defective electrodes, improper grounding, or faulty ECG equipment such as broken wires or cables. Some artifacts can mimic lethal dysrhythmias such as ventricular tachycardia. You can see this if your patient's brushing their teeth and they're on the monitor, or ventricular fibrillation, like if someone is accidentally tapping on their chest while they have an ECG in place. We want to always assess our patient to differentiate an artifact from an actual lethal rhythm, and we do not rely only on an ECG monitor to make diagnoses. So that was a lot of information. What does that mean to you? So we can utilize that information to determine the heart rate. The most common method is to count the number of QRS complexes in a 6-second strip and multiply that by the number of 10 to calculate the heart rate for a full minute. This is called a 6-second strip method and is a quick method to determine the mean or average heart rate. Normal heart rates fall between 60 and 100 beats per minute. A heart rate of less than 60 beats per minute is called bradycardia. A heart rate of greater than 100 beats per minute is called tachycardia. Current monitoring systems will display a continuous heart rate and print it on the ECG strip for you. We want to use caution and confirm that rate is correct by assessing the patient's heart rate directly. Many factors can incorrectly alter the display of the heart rate on the monitor. We want to determine the heart rhythm. We want to assess for atrial and or ventricular regularity. Heart rhythms can be either regular or irregular. Irregular rhythms can be regular irregular, occasionally irregular, or irregular irregular. We want to check the regularity of the atrial rhythm by assessing the P to P intervals, placing one caliper point at the P wave and the other on the other precise spot on the next P wave. Then we move the caliper from P wave to P wave along the entire strip to determine the regularity of the rhythm. P waves of a different shape or ectopic waves if present create an irregularity and do not regularly align with the other P waves. A slight irregularity in a PP interval varying no more than 3 small blocks is considered regular if the P waves are all of the same shape. This alteration is caused by changes in the intrathoracic pressure during the respiratory cycle. We also want to check the regularity of the ventricle system. So what that ventricular rhythm looks like by assessing the R to R intervals. We want to place one caliper point on the QRS complex, usually the most prominent portion of the deflection, and the other point on the precise spot of the next QRS complex. We move the calipers from QRS complex to QRS complex along the entire strip to determine the regularity of the rhythm. QRS complexes of a different shape, if present, create an irregularity and do not regularly align with the other QRS complexes. A slightly irregularity is no more than 3 boxes between intervals and again is considered regular in the QRS complexes if they're all the same shape. We want to analyze the P wave, check that the P wave shape is consistent throughout the strip, indicating that the atrial depolarization is occurring from impulses originating from one focus, normally the SA node. We want to determine whether there is one P wave occurring before each QRS. We want to establish that there's a relationship existing between the P waves and the QRS, and that this relationship indicates that there's an impulse from one focus is responsible for both atrial and ventricular depolarization. The nurse may observe more than one P wave shape, more P waves than QRSs, absent P waves, or P waves coming after the QRS, each indicating that a dysrhythmia is existing. We want to consider questions when analyzing that P wave, like are P waves present? Do the P waves occur regularly? Is there one P wave for each QRS? Are the P waves smooth, rounded, and upright in appearance? And do all the P waves look similar? Our fifth step in this is measuring that PR interval. We're going to place one caliper point at the beginning of the P wave and the other at the end of the PR segment. The PR interval normally measures at that 0.12 to 0.20 seconds. The measurement should be consistent throughout the strip. The PR interval cannot be determined if there are no P waves or if the P waves occur after the QRS complex. We want to consider the next three questions for a PR interval. Are PR intervals greater than 0.20? Are PR intervals less than 0.12? Are PR intervals constant across the ECG? For step 7, we're going to measure that QRS complex duration. We're going to place one caliper point at the beginning of the QRS complex and the other at the J points. We're going to measure from the QRS complex ends and where the ST segment begins. The QRS duration normally measures between 0.06 and 0.10 seconds. The measurement should be constant through the entire strip. Check the QRS complexes to assess whether or not we are consistent. When the QRS is narrow or less than 0.11 seconds, it indicates that the impulse was not formed in the ventriculars and is referred to as supraventricular origin. When this occurs, we know that we have an aberrant conduction, meaning there's deviating from the normal course or pattern. More than one QRS complex pattern or occasionally missing QRS complex patterns may be observed, and this is known as a dysrhythmia. We want to consider these questions when we're looking at that QRS interval. Are there QRS intervals less than or greater than the 0.11 second? Are the QRS complexes similar in appearance across the ECG paper? The last two things we look at are examining the ST segment. The normal ST segment begins at the isoelectric line. ST elevation or depression is significant if displacement is 1 millimeter or more above or below the line and is seen in 2 or more leads. ST elevation may indicate problems such as myocardial infarction, pericarditis, and hyperkalemia or high potassium. ST depression is associated with hypokalemia, low potassium, myocardial infarction, and ventricular hypertrophy. The last one we assess is the T wave. We're going to note the shape and height of the T wave for peaking or inversion. Abnormal T waves may indicate problems such as a myocardial infarction or a ventricular hypertrophy. When we're looking at the T wave, we can also do what's called a QT interval. A normal QT interval should be equal to or less than 1/2 the distance of the R-to-R interval. That was a lot of talking about what the terminology looks like, but let's look at some rhythm strips so you can really kind of nail down these ideas that we're talking about. I always like to start with what's normal. I feel like once we understand what's normal, we can move on to looking at some of our dysrhythmias. So this first slide is going to be about normal sinus rhythm. When we're looking at this slide, we know that this patient, as for our ECG strip, is doing well. So with normal sinus rhythm, both the atrial and ventricular rhythms are essentially regular. There could be a slight variation, like we talked about, in your rhythm, but still normal. Arterial and ventricular rates are both 83 beats per minute. So when we're counting this out on that 6-second strip, I can see I have 1, 2, 3, 4, 5, 6, 7, 8 beats on there, and it looks like I'm starting up another one just as that 6-second strip leads. There is one P wave before each QRS complex, so again that adds to our regularity, and all of our P waves are of a consistent morphology or shape. The PR interval for this one is measuring 0.18 seconds and is constant, and the QRS complex is measuring 0.06 seconds and is constant. So we would determine that this rhythm strip is a normal sinus rhythm. Just to reiterate what's normal, normal sinus rhythm is a rhythm originating from the SA node or that dominant pacemaker that meets these ECG criteria. So the rate, the atrial and ventricular rates will be between 60 and 100 beats per minute. The rhythm of the atrial and the ventricular rhythms will be regular. There will be a P wave that is present, consistent configuration, and there will be only one P wave for each QRS complex. Our PR interval will be between that 0.12 to 0.20 seconds and constant, and then that QRS duration will be between 0.06 and 0.11 and constant. So let's assess your knowledge. We've talked about sinus rhythm for a few slides now. So I'm telling you at the top of the slide that both of these ECG strips are sinus rhythm. But what you're noticing is they look very different. So the top slide, we're looking at a sinus rhythm, but when I count out that 6-second strip, let's see here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, I'm looking at a heart rate of 110 beats per minute. My PR is still normal, it's a 0.12, and the QRS complex is 0.08 seconds, so I can say that it's sinus rhythm, but what are you noticing about that heart rate? We talked about a normal sinus rhythm being a heart rate of 60 to 100. So if I'm counting 110, we're going to call this one a sinus tachycardia. Our sinus strip, our EKG strip sinus rhythm B is looking much slower. So when I count that 6-second strip, I'm actually counting a heart rate of 50 beats per minute. Our PR rate would be a 0.18, and our QRS complex would be a 0.08 seconds. So I'm still a sinus rhythm, but I'm called sinus bradycardia. The next thing we'll talk about is sinus arrhythmias. So when we talk about a sinus arrhythmia, we're looking at variance from the normal sinus rhythm. This can be a rate, so the atrial or ventricular rate is between that 60 to 100 beats. When we're looking at this, we're wanting to see that the rhythm, the atrial and the ventricular rhythms are regular with a arrhythmia. So this could be a shorter P to P wave or an R to R interval that's varying at least 0.12 seconds from the longest PP to RR ratio. The P wave, one P wave before each QRS complex, but that has to be consistent in configuration. And then that PR interval is still normal and constant, and then that QR duration is still normal and constant. Common dysrhythmias we may see are premature complexes that may occur repetitively in the rhythmic fashion. Bigeminy exists when this normal complex and premature complexes occur alternately in a repetitive 2-beat pattern, with a pause occurring after each premature complex, so complexes occur in pairs. Trigeminy is a repeated 3-beat pattern, usually occurring at 2 sequential normal complexes followed by a premature complex and a pause, with the same pattern repeating itself in triplets. A quadremedy is a repeated 4-beat pattern, usually occurring with 3 sequential normal complexes followed by a premature complex, then a pause, with the same pattern repeating itself in a 4-beat pattern. Bradydysrhythmias occur when the heart rate is less than 60 beats per minute. These rhythms also can be significant because it shows that myocardial oxygen demand is reduced from a slow heart rate, which can be beneficial. Coronary perfusion time may be adequate because of the prolonged diastole, which is desirable. And then coronary perfusion pressure may decrease if the heart rate is too slow to provide adequate cardiac output and blood pressure, and this can be a serious consequence. Therefore, the patient may tolerate a bradydysrhythmia well if the blood pressure is adequate. If the blood pressure is not adequate, symptomatic bradyarrhythmias may lead to myocardial ischemia or infarction, dysrhythmias, hypotension, and heart failure. Tachyarrhythmias of the heart means that that heart rate is greater than 100 beats per minute. They are a major concern in the adult patient with coronary artery disease. Coronary artery blood flows occur most during our diastole when the aortic valve is closed and is determined by diastolic time and blood pressure in the root of the aorta. Tachydysrhythmias are serious because they shorten the diastolic time and therefore the coronary perfusion time, the amount of time available for blood flow to hit the coronary arteries of the myocardium. Initially, this increases the cardiac output and blood pressure. However, a continued rise in the heart rate decreases our ability to have ventricular filling. which can shorten diastole, decreasing our stroke volume. So consequently, cardiac output and blood pressure will begin to decrease, reducing aortic pressure and therefore coronary perfusion pressures. This increases the work of the heart, which increases our myocardial oxygen demand. The patients with a tachydysrhythmia may have palpitations, they may have chest discomfort or pressure or pain from myocardial ischemia or infarction, restlessness and anxiety, pale, ashy, gray, cool-colored skin. They may black out or have a syncopal episode from hypotension. And tachydysrhythmias may also lead to heart failure, presenting symptoms of heart failure, which can be dyspnea, lung crackles, distended neck veins, fatigue, and weakness. So talk about the natural pacemaker of the heart, the SA to AV node going down to the bundle branches. But when we have a patient who is Brady, we may have to give them a artificial pacemaker. So temporary pacing is a non-surgical intervention that provides a timed electrical stimulus to the heart when either the impulse initiation or the conduction system of the heart is defective. The electrical stimulus then spreads throughout the heart to depolarize the cells, which should be followed by contraction and cardiac output. Electrical stimuli may be delivered to the right atrium or the right ventricle, a single chamber pacemaker, or by a dual chamber pacemaker. Temporary pacer is used for a patient with symptomatic bradycardia who do not respond to atropine, or with patients who are asystole. These are two types of temporary pacing. There's transcutaneous and transvenous. Transcutaneous pacing is accomplished through the application of two large electronic external electrodes. The electrodes are attached to an external pulse generator. The generator emits electrical pulses, which are transmitted through the electrodes and then transcutaneously to stimulate ventricular depolarization when the patient's heart rate is slower than the rate set on the pacemaker. Transcutaneous pacing is used as an emergency measure to provide demand ventricular pacing in a profoundly bradycardic or asystolic patient until invasive pacing can be used for the patient's heart rate to return to normal. This method of pacing is very painful and may require administration of pain medication and sedation for a patient to tolerate the therapy. Transcutaneous pacing is used only as a temporary measure to maintain heart rate and perfusion until a more permanent method can be used. A temporary transvenous system can be inserted in an emergency as a bridge until the permanent pacemaker can be inserted. This system consists of an external battery-operated pulse generator and pacing electrodes or lead wires. The wire attaches to the generator on one end of the thread to the right ventricle via the subclavian or femoral vein. Permanent pacemaker insertion is performed to treat conduction disorders that are not temporary, including a complete heart block. These pacemakers are usually powered by a lithium battery and have an average life of about 10 years. After the battery power is depleted, the generator must be replaced by means of the procedure being done again with the patient under local anesthetic. Some pacemakers can be recharged externally. These combination pacemakers and defibrillators are also available. A biventricular pacemaker may be used to coordinate contractions between the right and the left ventricle. In addition to pacing used for the right side of the heart, we have an additional lead, which is placed in the left lateral wall of the left ventricle through the coronary sinus, and this procedure causes synchronized depolarization of the ventricles and is used when a patient has moderate to severe heart failure to improve the functional ability. Now let's talk about PACs. PAC is a premature atrial complex, and it occurs when atrial tissue becomes irritable. This ectopic focus fires an impulse before the next sinus impulse is due. The premature P wave may not always be clearly visible because it is hidden in the preceding T wave. We want to examine the T wave closely for any changes in shape and compare with the other T waves. A PAC is usually followed by a pause. The causes of atrial irritability include stress, fatigue, anxiety, inflammation, infection, caffeine, nicotine, or alcohol use. Drugs such as epinephrine, symptomathetics, amphetamines, digoxin, and anesthetics can also throw PACs. PACs may also result from myocardial ischemia, hypermetabolic states, electrolyte imbalances, or atrial stretch. Atrial stretch can result from congestive heart failure, valvular disease, and pulmonary hypertension with cor-pulmonal. The patient usually has no symptoms except for possible heart palpitations. No intervention is needed except to treat causes such as heart failure. If PACs occur frequently, they may lead to more serious atrial tachycardia dysrhythmias and therefore would need to be treated. Administration of prescribed antidysrhythmic drugs may be necessary. We want to teach the patient to measure and to manage stress and substances to avoid, such as caffeine or alcohol, that we are knowing create that increase in atrial irritability. Supraventricular tachycardia, or SVT, involves the rapid stimulation of the atrial tissue to a rate of 100 to 280 beats per minute in adults. During SVT, P waves are not visible, especially if there's a one-to-one conduction with rapid rates, because P waves are embedded in the preceding T waves. SVT may occur in healthy young adults, especially women. SVT is usually caused by a re-entry mechanism in which one impulse circulates repeatedly throughout the atrial pathway, re-stimulating the atrial tissue to a rapid rate. The term paroxysmal supraventricular tachycardia, or PSVT, is used when rhythm is intermittent. It is initiated suddenly by a PVC or a PAC and then terminated suddenly with or without intervention. We can also use a vagal maneuver, inducing that vagal stimulation of the cardiac conduction system, specifically the SA and the AV nodes. Although it's not commonly used today, vagal maneuvers may be attempted to treat supraventricular tachydysrhythmias and include carotid sinus massage and Valsalva maneuvers. However, the results of these interventions are often temporary and may cause what's called rebound tachycardia or severe bradycardia, and then further treatment must be initiated. So now we'll move on to atrial fibrillation. Atrial fibrillation is the most common dysrhythmia seen in the clinical practice. Atrial fibrillation can be encountered and treated in the ambulatory and acute care settings. It can impair quality of life and cause considerable morbidity and mortality, largely related to clotting concerns such as an embolytic stroke, DVT, or deep vein thrombosis, and pulmonary embolism. Atrial fibrillation is associated with atrial fibrosis and loss of muscle mass. These structural changes are common in heart disease such as hypertension, heart failure, and coronary artery disease. For those without an underlying disorder leading to the development of AFib, like genetic mutations have been identified as a potential cause. As atrial fibrillation progresses, cardiac output decreases by as much as 20 to 30%. Atrial fibrillation is the most common dysrhythmia in the developed world, currently estimated to affect 12.1 million people in the United States by the year 2030. That's through the Center of Disease Control and Prevention. The instance of atrial fibrillation increases with age. Atrial fibrillation causes serious problems in older people, leading to stroke and or heart failure. Risk factors include hypertension, previous ischemic stroke, TIAs or transient ischemic attacks, or thrombolytic events, coronary artery disease, diabetes mellitus, heart failure, obesity, hyperthyroidism, chronic kidney disease, excessive alcohol use, and mitral valve disease. When obtaining a history, we want to assess the prior history of any atrial fibrillation or any other dysrhythmias. Recurrence of atrial fibrillation is common, and assessment of previous conduction issues can be helpful in developing the plan of care. We want to assess the history of cardiovascular disease. The risk of atrial fibrillation is much higher in patients with a history of hypertension, heart failure, obesity, and acute coronary syndrome. On our physical assessment, we will see that the apical pulse may be irregular. Symptoms depend on the ventricular rate, though. Because of the loss of the atrial kick, the patient in uncontrolled atrial fibrillation is at greater risk for inadequate cardiac output. Signs of poor perfusion may be observed. We want to assess the patient for fatigue, weakness, shortness of breath, dizziness, anxiety, syncope, palpitations, cardiac discomfort or pain, and hypotension. Some patients may also be asymptomatic. So it's important you also look at the psychosocial of your patient. So patients with atrial fibrillation, especially those with high ventricular rates, can feel very anxious. When increased heart rate, the cardiac output decreases, which can cause shortness of breath, contributing to feelings of anxiety. We want to assess the patients who have chronic atrial fibrillation for methods of coping with long-term conduction issues. Patients with chronic atrial fibrillation may have anxiety related to anticoagulation medications and a potential for an emboli to develop. Some diagnostic assessments we might do would be a definitive diagnosis occurring by obtaining that 12-lead EKG. We want to have it classified into one of the 5 categories based on the length of time of the rhythmal, the paroxysmal, persistent, long-standing, persistent, permanent, and non-valvular. Atrial fibrillation is termed paroxysmal when the patient experiences an episode within 7 days, then converts back to sinus rhythm. Episode lengths vary, but do not continue beyond a week. Persistent AFib is experienced as episodes that occur for longer than 7 days. Atrial fibrillation sustained for more than 12 months is categorized as a long-standing persistent. And then permanent atrial fibrillation is defined as a patient who remains in AFib, and a decision is made not to restore or maintain sinus rhythm by either medical or surgical intervention. Non-valvular atrial fibrillation occurs in the absence of a mitral valve disease or repair. So the priority collaborative problems for most patients with atrial fibrillation are the potential for ambulus formation due to the irregular cardiac rhythm and the potential for heart failure due to the altered conduction pattern. Interventions for atrial fibrillation depend on the severity of the problem and the patient's response. We want to be sure to individualize care based on the patient's values and preferences, your clinical expertise, and best current evidence. Drug therapy is often effective for treating atrial fibrillation. We want to prevent the ambulus formation. Planning, we want to do expected outcomes, which would be that our patient remains free of ambulus formation by restoring regular cardiac conduction. The purpose of collaborative care is to restore our regular blood flow through the atrium when possible. Correcting the rhythm and controlling the rate of the rhythm restores that blood flow, which helps prevent ambulus formation and increases that cardiac output. Drug therapy is often effective when treating atrial fibrillation. We also want to prevent heart failure. So in order to do that, the expected outcome is that the patient will remain free of heart failure through restoration of normal conduction with a controlled ventricular rate. Our interventions will be at that collaborative care to prevent heart failure and improve cardiac output, generally begin with drug therapy. However, the patient may require other non-surgical or surgical interventions if medication is not successful with our optimal outcomes. The expected outcome is that the patient will remain free from heart failure through restoration of normal conduction with a controlled ventricular rate. We use collaborative care to prevent heart failure and improve cardiac output, generally beginning with that drug therapy, but like I said, they might need surgery. When we do non-surgical interventions, most commonly this would be like an electrical cardioversion, a left atrial appendage closure, radiofrequency catheter ablation, and pacing. For electrical cardioversion, our patient is synchronized with a shock that can be performed to restore normal conduction in the hospital, and that can be used for a patient with new onset atrial fibrillation. Cardioversion can also be scheduled electively for stable patients that are resistant to medical therapy. When the onset of atrial fibrillation is greater than 48 hours, the patient must be taking anticoagulants for at least 3 weeks, or until the INR is between 2 to 3 before the procedure can be done to prevent blood clots from moving from the heart to the brain or lungs. If the onset of AFib is uncertain, they'll do what's called a TEE, or a transesophageal echocardiography, to obtain whether or not there are blood clots formed in the left atrium. The shock depolarizes a large amount of myocardial during the cardiac depolarization, and is intended to stop the re-entry circuit and allow the sinus node to regain control of the heart. Emergency equipment must be available during this procedure. The physician, advanced practice nurse, and/or qualified nurses need to explain the procedure to the patient and the family. We have to help the patient sign a consent form unless the procedure is an emergency for a life-threatening dysrhythmia. Because the patient is usually conscious, the short-acting anesthetic agent is administered for sedation. One electrode is placed on the left of the precordium, and the other is placed on the right next to the sternum and below the device of the clavicle. The defibrillator should be set to a synchronized mode. A dot or line will be indicated over each QRS complex, confirming the synchronized mode. This avoids discharging the shock on a T wave, which could result in ventricular irritability, and we could actually send our patient into ventricular fibrillation. So we don't want to do that. We want to charge the defibrillator to the energy level requested by the provider, usually starting at lower rates of 120 to 200 joules for biphasic machines. So what are some of the nursing safety priorities? These are critical. We want to be prepared for a rescue. So for safety, before a cardioversion, we want to turn oxygen off and remove it from the patient. This could result in a fire when we're expelling a shock. We want to shock clear before we deliver that shock for electrical safety. Don't shock your friends. After cardioversion, assess the patient's response and heart rhythm. Therapy is repeated if necessary until the desired result is obtained, or alternative therapies can be considered. If the patient's condition deteriorates into ventricular fibrillation after cardioversion, we have to check to see the synchronizer is turned off so immediate defibrillation can be administered. So nursing care after cardioversion, we want to make sure that that patient is maintaining their airway. We want to administer oxygen, assess the vitals and the level of consciousness. We want to administer any anti-dysrhythmic drug therapy as prescribed. We want to monitor for dysrhythmias. We want to assess for any chest burns from the electrodes. We want to provide emotional support and then document the results of the cardioversion. For left atrial appendage closure, this is for patients who are at a high risk for stroke and who are not candidates for long-term anticoagulation. So the left atrial appendage clip or occlusion device may be an option. The LAA is a small sac in the wall of the left atrium. For those with non-valvular atrial fibrillation, the LAA is the most common site of a blood clot formation, which can lead to the development of a stroke. So they insert a percutaneously via the femoral vein. A device to occlude the LAA is delivered via a transeptal puncture. In the United States, the Watchman procedure is also utilized, which is a neotidal frame with fenestrated fabric, and it's the only device approved for such uses for atrial fibrillation patients. After insertion, anticoagulation with aspirin and warfarin are required. Repeat TEE is performed about 40 to 45 days after insertion to assess for leaks around the device. If no leak is detected, the warfarin is stopped and antiplatelet therapy can be continued. Complications are similar to those for a cardiac ablation procedure. Now, when we talk about a radiofrequency catheter ablation, it is an invasive procedure that may be used to destroy an irritable focus in the atria or ventricular conduction. The patient must first undergo a EP study or an electrophysiologic study and map the procedure to locate the foci that are causing the problem. Then radiofrequency waves are delivered to abolish the irritable focus. When ablation is performed in the AV nodule or the bundle of His, damage may also occur in the neural conduction system, which can cause heart blocks and necessitate the implementation of a permanent pacemaker. In atrial fibrillation, pulmonary vein isolation and ablation create scar tissue that blocks the impulse and disconnects the pathway of the abnormal rhythms. Patients with AFib who are in what's called a RVR or a rapid ventricular rate that's not responding to drug therapy may have an AV nodule ablation performed to totally disconnect the conduction from the atria to the ventricles, and this may require implementation of a permanent pacemaker. Atrial fibrillation ablation should not be performed in long-term anticoagulation if long-term anticoagulation is contraindicated. When we talk about biventricular pacing, this type of pacing may be another alternative for patients with heart failure and conductive disorders. Biatrial pacing, anti-tachycardial pacing, and implantable atrial defibrillators are other methods that we can use to suppress or resolve atrial fibrillation. As far as surgical interventions go, patients in AFib with heart failure may benefit from what's called a surgical maze procedure, which is an open heart surgical technique often performed with coronary artery bypass grafting. Before the procedure, a EP mapping study are done to confirm the diagnosis of AFib. The surgeon then places a maze of sutures in strategic places in the atrial myocardium, pulmonary artery, and possibly the superior vena cava to prevent electrical circuits from developing and continuing AFib. Sinus impulses can then depolarize the atria before reaching the AV node and preserve the atrial kick. Post-operative care is similar to that after the open heart surgical procedures. The surgical maze procedure is being replaced by catheter procedures, though, because those are more minimally invasive. The catheter maze procedure is done by inserting a catheter through a vein in the leg to the atrial and dragging a heated ablation catheter along the atrial to create scars. to block that conduction. Patients have a minimally invasive form of this procedure, have fewer complications, less pain, and a quicker recovery than those with the open surgical maze procedure.
So with atrial fibrillation, we have to talk about care, coordination, and transition management. Patients and their families must have a thorough understanding of the prescribed medication therapy, including antidysrhythmics and anticoagulant agents. Pharmacies provide written instructions with filled prescriptions. We need to teach the family and the patient the generic and trade names of their drugs and the drug's purposes, using basic terms that are easy to understand. Clear instructions regarding dosage schedules and common side effects are important. We need to emphasize the importance of reporting these side effects and any dizziness, nausea, vomiting, chest discomfort, or shortness of breath to the primary care provider. We want to be sure to include in the education that the medication should not be stopped abruptly unless instructed by the primary health care provider. We also want to teach the patient any signs and symptoms of bleeding, advise the patient to call the provider with any signs or symptoms of bleeding have been identified. We want to teach all patients and their family members how to take a pulse and a blood pressure. Some patients may want to use technology to calculate and record their pulse rate. Several applications and apps from handheld mobile devices such as the iPhone are available, but their accuracy varies. Instant heart rate and quick heart rate are examples of apps that can be utilized to calculate the pulse rate. The Apple Watch includes an EKG app specifically designed to detect atrial fibrillation. The device is FDA cleared for over-the-counter use to help identify, but not diagnose, atrial fibrillation. Clearance has been given to allow this device to keep track of a person's atrial fibrillation data, allowing deeper insight into the condition for the patient and the healthcare provider. We need to remind patients to report any signs of a change in heart rhythm, such as a significant decrease in the pulse rate, or a rate of more than 100 beats per minute, or increased rhythm irregularity. Smart blood pressure is a blood pressure sign monitoring. We need to make sure that patients feel comfortable with these monitoring systems and how they record, track, and analyze data on the iPhone or iPad. The patient can then send the readings to the primary health care provider as needed to maintain frequent vital sign monitoring. The cardiac rehabilitation nurse typically provides written and oral information about dysrhythmias, antidysrhythmic drugs, and anticoagulant drugs. In addition, information about cardiac exercise programs, educational programs, and support groups is provided. The office or ambulatory care nurse may also provide information about resources. We need to teach the patient how to contact the local chapter of the American Heart Association or the provincial chapter of the Heart and Stroke Foundation in Canada for information about dysrhythmias, pacemakers, and CPR training. For evaluation of atrial fibrillation, we look on the basis of identified patient problems. So the expected outcomes for this patient would be remaining free of embolus formation associated with atrial fibrillation and remaining free of heart failure with regular heart rate and rhythm control. With ventricular dysrhythmias, we see PVCs, or premature ventricular complexes. They're also called premature ventricular contractions, and they result from increased irritability of ventricular cells and are seen as early ventricular complexes followed by a pause. When multiple PVCs are present, the QRS complexes may be unifocal or uniform, meaning that they are all the same shape, or multifocal or multiform, meaning that they are different shapes. PVCs frequently occur in repetitive rhythms, such as bigeminy or 2, trigeminy or 3, and quadreminy or 4. Two sequential PVCs are a pair or a couplet. Three or more successive PVCs are usually known as non-sustained ventricular tachycardia, or NSVT. The patient may be asymptomatic or may experience palpitations or chest discomfort caused by increased stroke volume of the normal beat after the pause. Peripheral pulses may be diminished or absent with the PVCs themselves because the decreased stroke volume of the premature beats may decrease peripheral perfusion. In the picture, you will see ventricular dysrhythmias. The first picture is a normal sinus rhythm with unifocal PVC complexes. In our strip B, we're seeing a normal sinus rhythm with multifocal PVCs. So we see one with a negative deflection and one with a positive deflection. Ventricular dysrhythmias are potentially more life-threatening than atrial dysrhythmias because the left ventricle pumps oxygenated blood throughout the body to perfuse vital organs and other tissues. The most common or life-threatening ventricular dysrhythmias include premature ventricular complexes and ventricular tachycardia. Premature ventricular contractions are common, and they're frequently increased with age. They may be insignificant or may occur with problems such as myocardial infarction, chronic heart failure, chronic obstructive pulmonary disease or COPD, and anemia. PVCs may also be present in patients with hypokalemia or hypomagnesemia. Sympathetic agents, anesthetic medications, stress, nicotine, caffeine, alcohol, infection, or surgery can also cause PVCs, especially in older adults. Postmenopausal women often find that caffeine causes palpitations in PVCs. Ventricular tachycardia, or VT, sometimes referred to as VTAC, occurs with repetitive firing of an irritable ventricular ectopic focus, usually at a rate of 140 to 180 beats per minute or more. VT may result from increased automaticity or a re-entry mechanism. It may be intermittent or non-sustained SVT or sustained, lasting longer than 15 to 30 seconds. The sinus node may continue to discharge independently, depolarizing the atria but not the ventricles, although P waves are seldom seen in sustained VT. Ventricular tachycardia may occur in patients with ischemic heart disease, myocardial infarction, cardiomyopathy, hypokalemia, hypomagnesia, valvular heart diseases, heart failure, drug toxicity like with steroids, or hypotension. Patients who use cocaine or illicit inhalants are at a high risk for a VT. In patients who go into cardiac arrest, VT is commonly the initial rhythm before deterioration into ventricular fibrillation as the terminal rhythm. Signs and symptoms of sustained VT partially depend on the ventricular rate. Slower rates are better tolerated. What you see above is what's called a coarse ventricular fibrillation. Ventricular fibrillation, sometimes called VFib, is the result of electrical chaos in the ventricles and is life-threatening. Impulses from many irritable foci fire in a totally disorganized manner, so ventricle contractions cannot occur. There are no recognizable ECG deflections. The ventricles merely quiver, consuming a tremendous amount of oxygen. There is no cardiac output or pulse, and therefore no cerebral myocardial or systemic perfusion. This rhythm is rapidly fatal if it is not successfully ended within 3 to 5 minutes. Ventricular fibrillation may be the first manifestation of coronary artery disease. Patients with myocardial infarction are at a great risk of VFib. It may also occur in those with hypokalemia, hypomagnesia, hemorrhage, drug therapy, rapid supraventricular tachycardia, or shock. Surgery or trauma may also cause VFib. Emergency care for VFib is critical for survival. When VFib begins, the patient becomes faint, immediately loses consciousness, and becomes pulseless and apneic. There is no blood pressure and heart sounds are absent. Respiratory and metabolic acidosis develop. Seizures may occur. Within minutes, the pupils become fixed and dilated, and the skin becomes cold and mottled. Death results without prompt intervention. The desired outcomes of collaborative care are to resolve the VFib promptly and convert it to its original rhythm. Therefore, the priority is to defibrillate the patient immediately according to ACLS protocol. If a defibrillator is not readily available, high-quality CPR must be initiated and continued until the defibrillator arrives. An automatic external defibrillator, or an AED, is frequently used because it is simple to use for both medical and lay personnel. Defibrillation is discussed with the CPR later in this chapter. Drug therapy is used with dysrhythmias are sustained and or life-threatening. Drug therapy from one or more classes of antidysrhythmic agents is often used. Other medications that can be used include epinephrine and magnesium sulfate. Epinephrine should be administered after 2 minutes of CPR in shockable rhythms after the first shock has been delivered. Magnesium sulfate is an electrolyte administered to treat refractory VT or VFib because the patient may have hypomagnesia, which increases ventricular irritability. The drug is also used for the life-threatening ventricular tachycardia called torsades de pointes, which may result from certain antidysrhythmics such as amiodarone. The picture above is a ventricular asystole with one idioventricular complex. Ventricular asystole, sometimes called Ventricular standstill is a complete absence of any ventricular rhythm. There are no electrical impulses in the ventricles and therefore no ventricular depolarization, no QRS complex, no contraction, no cardiac output, and no perfusion to the rest of the body. When cardiac arrest occurs, cardiac output stops. The underlying rhythm is usually ventricular tachycardia, ventricular fibrillation, or asystole. Without cardiac output, the patient is pulseless and becomes unconscious, becoming of inadequate cerebral perfusion and gas exchange. Shortly after cardiac arrest, respiratory arrest occurs. Therefore, cardiopulmonary resuscitation is essential to prevent brain damage and death. Cardiopulmonary resuscitation and defibrillation. So with CPR, also known as basic life support, we must be initiating this immediately when asystole occurs. When finding an unresponsive patient after confirming that the scene is safe, we confirm unresponsiveness and call 911. Or, if we're the emergency response team in the hospital, we gather the AED or defibrillator before initiating CPR. Guidelines for CPR have changed from an ABC or airway breathing compressions approach to the initial priorities of CAB, which are compressions, airway, breathing. We want to check for a carotid pulse for no more than 5 to 10 seconds. If the carotid pulse is absent, we start CPR compressions of 100 to 120 compressions per minute and a depth of at least 2 inches with no more than 2.4 inches. We want to push hard and fast. Avoid leaning into the chest after each compression to allow for full chest wall recoil. And these are all for adult measurements. We want to maintain a patent airway. Ventilating or breathing with the mouth-to-mask device. We want to give rescue breaths at a rate of 10 to 12 breaths per minute. And in advanced airways in place, 1 breath should be given every 6 to 8 seconds, or 8 to 10 breaths per minute. We want to limit interruptions to compressions to less than 10 seconds. When possible, compressors should be changed every 2 minutes to maintain effective compressions. A CPR coach should be assigned to the cardiac arrest response team to coordinate, communicate, and maintain effective CPR. We want to be sure to use standard precautions when administering CPR. For patients with COVID-19, all healthcare workers should wear a respirator or an N95, along with other patient protective equipment while performing CPR. A high-efficiency particulate air or HEPA filter should be attached to any ventilation device, and endotracheal administration of medication should be minimized to avoid aerosolization. We want to be aware that complications do occur from CPR. Those include rib fractures, fracture of the sternum, costal choroidal separation, lacerations of the liver and spleen, pneumothorax, hemothorax, cardiac tamponade, lung contusions, and fat embolisms. When we talk about defibrillation, we talk about asynchronous countershocks that depolarize a critical mass of myocardium simultaneously to stop the re-entry circuit, allowing the sinus node to regain control of the heart. As soon as help arrives, we place a board under the patient who is not on a firm surface. To make room for resuscitation team in the crash cart, we ask that the area be cleared of movable items and unnecessary personnel. When the AED or defibrillator arrives, do not stop chest compressions while the defibrillator is being set up. If trained to use the AED or defibrillator, apply hands-off defibrillator pads to the patient's chest and turn on the monitor. If the patient is in VFib or a pulseless VTAC, the immediate priority is to defibrillate. Defibrillation is utilized to try to get that heart to maintain back into that regular heart rhythm. After defibrillation, CPR is resumed. CPR must continue at all times except during defibrillation. The American Heart Association promotes the use of the automatic external defibrillators, or AEDs, for use by laypersons and healthcare professionals responding to cardiac arrest emergencies. These devices are found in many public places such as malls, airports, and commercial jets. The patient in cardiac arrest must be on a firm, dry surface. The respirator must place 2 large adhesive patch electrodes on the patient's chest in the same positions as the defibrillator electrodes. The rescuer stops CPR and commands anyone present to move away, ensuring that no one is touching the patient. This measure eliminates motion artifact when the machine analyzes the rhythm. The rescuer presses the Analyze button on the machine. After rhythm is analyzed, the machine advises that a shock is either necessary or not indicated. Shocks are recommended for ventricular fibrillation or pulseless ventricular tachycardia only. If a shock is indicated, issue a command to clear all contact from the patient and press the charge button. Once the AED is charged, press the shock button and the shock will be delivered. The shock is delivered through the patches, so it's hands-off defibrillation, which is safer for the rescuer. The rescuer then resumes CPR until the AED instructs to stop CPR to analyze the rhythm. If the rhythm is VFib or VTAC and another rhythm is indicated, the AED will instruct the rescuer to charge and deliver another shock. New AEDs perform rhythm analysis and defibrillation without the need for the rescuer to press the button to analyze or shock the victim. It is essentially that the ACLS be provided as soon as possible. Use of AEDs allows for early defibrillation. Therefore, there is a greater chance of successful rhythm conversion and patient survival. This is a picture of an AED. These are kept in malls and hospitals. These are for lay people to utilize, and you can see by the ease of the buttons why that would be there. The green button is the on button, and the little lightning mark is the shock button. The implantable cardioverter defibrillator, or ICD, is indicated for patients who have experienced one or more episodes of spontaneous sustained ventricular tachycardia or ventricular fibrillation not caused by a myocardial infarction. Collaborate with the physician and the electrophysiology nurse to prepare the patient for this procedure. Two types of lead systems are available, that's transvenous and subcutaneous. In the traditional transvenous system, the leads are introduced through the subclavian vein and the generator is implanted in the left pectoral area, similar to a pacemaker insertion. In the subcutaneous ICD, the leads are tunneled underneath the skin and placed into the left of the sternum to form a right angle just above the xiphoid, where they attach to the generator. The generator is implanted in the left mid-axillary chest wall. The subcutaneous ICD is recommended for younger patients less than 40 years of age, patients without venous access, and patients who do not require concomitant pacemaker therapy. The procedure is performed in the electrophysiology lab. If the patient experiences a VTAC or VFib episode after the ICD is placed and the ICD therapies are not successful, the qualified nurse or healthcare provider promptly externally defibrillates and initiates the high-quality CPR. Some patients use a lightweight, automatic, wearable cardioverter defibrillator, a WCD. This external vest-like device is worn 24 hours a day, except for when the patient showers or bathes. One popular brand is the Zoll LifeCore Life Vest, which is programmed to monitor for VTAC and VFib. A family member must be present to call 911 and initiate CPR if the patient experiences pulseless VT or VFib while in the shower. If patients are conscious while experiencing VTAC, they can press a button to prevent a shock. This precaution is an advantage over implantable devices because ICDs are programmed to always deliver a shock when VTAC or VFib occurs. The generator may be activated or deactivated by the provider, placing a magnet over the implantation site for a few moments. The patient requires close monitoring in the postoperative period for dysrhythmias and complications such as bleeding and cardiac tamponade. The nurse must know whether the ICD is active or deactivated. Care of the patient is similar to that after a permanent pacemaker discussed earlier in this chapter. If the device was implanted following sudden cardiac arrest, driving is usually restricted for 6 months.